Okay, very good afternoon to everyone. Thank you very much for joining on this afternoon. So topic is deep vein thrombosis, DVT as is commonly known. It's an old problem, but let's talk about something new about it. So the reason I choose to talk about this topic today is I see a lot of DVTs, many cases of DVTs, especially during the previous MCO. There's been a spike in the number of DVTs. Most of them presented quite acutely and quite serious. So before we start, I just want to introduce one of the patients, real patients, just to get a taste of it. He's a 32-year-old man. He had a deep vein thrombosis 7 years ago. So 7 years ago, he was treated with only anticoagulation. And because the deep vein thrombosis was very serious, in a sense that the blood clots were quite proximal in the iliac veins, he was fitted with an IVC filter, inferior vena cava filter, that is to filter the blood clot from traveling to the lungs and getting a pulmonary embolism. Bearing in mind it's permanent. Now he's come to me because he has recurrent deep vein thrombosis. And not only that, he has recurrent leg ulcers. And that's what his leg looks like. So imagine he's a 32 years old man. He has to work, he has to support his family, and is the only sole breadwinner for the family. Okay, so that's his leg looks like, very swollen. You can see this collateral on the leg, and for the skin changes, which is consistent with chronic venous insufficiency. So, why did his leg become like this? We need to ask ourselves. Treatment with anticoagulation at the time, was it sufficient? Permanent IVC filter, is that the right thing to do? Should it be removed? Should it be permanent? Okay, so I'll come back to that later. And for the introduction, deep vein thrombosis is more commonly known as DVT. It's a manifestation of venous thromboembolism, VTE. So the issue with this is remains underdiagnosed. It's underdiagnosed, and most of the times patients are diagnosed during autopsy with a pulmonary embolism. So this is a very serious condition which should not be missed, and if it's missed, it can be fatal. What's the pathophysiology? As we all know, it's represented by this Burkhouse triad, which consists of hypercoagulability, vascular damage or vascular endothelial damage, and stasis to the circulation. In cases of hypercoagulability, the commonest factors are estrogen therapy, inflammation, dehydration. And of course, there are other systemic risk factors such as autoimmune conditions, such as SLE, inflammatory bowel disease, inherited thrombophilia, pregnancy, malignancy, major surgery, infection, and sepsis. So, as a surgeon, patients coming in for major surgeries, we always like to give prophylaxis treatments for DVTs. As for the circulatory stasis, immobility is a major risk factor, especially those at home during MCOs, don't move about too much. Venous obstruction, such as obesity or tumor that is pressing against the pelvic veins, varicose veins, atrial fibrillation, and congenital abnormalities, which we as vascular surgeons deal a lot with. For example, May-Turner syndrome. May-Turner syndrome means that the left iliac vein is pressed upon by the right iliac artery, and therefore it causes circulatory stasis down below in the pelvis and the thigh and the whole lower limb, and therefore is prone to get proximal DVT and a low heart rate or low blood pressure, obviously, as the system is not pumping and the blood is not flowing fast enough. In terms of the vascular damage, it could be a thrombophlebitis, which means there's a blood clot and inflammation of the veins, which can happen commonly in the varicose veins, or cellulitis, or cholesterol plaques, or even it could be iatrogenic, as in an indwelling catheter, such as a permanent catheter that's been put in the veins for venous access, venipuncture, trauma to the vessel wall, or physical trauma, strain, or injury. So that's the pathophysiology of venous thromboembolism, VTEs. So what are the symptoms? So in the primary care, I'm sure a lot of patients will come with complaints to their legs or the lower limbs. And the most specific symptom for DVT is edema. You can see that the leg is swollen compared to the other leg. What about leg pain? It's not very specific, and it occurs in only 50% of the patients. Tenderness, again, not so specific, as it's only in 75% of the patients. Warmth or erythema of the skin or the area of thrombosis, sometimes the leg can present as a cellulitis, redness, and swelling over the leg. Or in more serious conditions, they may present as a complication of DVT, such as symptoms of a PE, shortness of breath, pleuritic chest pain. So these are the symptoms. So in essence, not many of these symptoms you can tell that somebody has a DVT conclusively. So what about the physical examination of signs? There is no there's no one single physical finding or combination of symptoms and signs is sufficiently accurate to establish the diagnosis of DVT. So in essence, clinically, it is not easy to say clearly that somebody has a DVT or somebody does not have a DVT. What about Hohmann's sign that we learn in the medical school? Hohmann's sign is actually by keeping the leg extended, and we dorsiflex the foot, and patients complains of pain. So it is neither sensitive nor specific, as it is present in only less than 1/3 of patients with confirmed DVT, and is found in more than 50% of patients without DVT. So it's not very helpful. It's not worth doing it. If somebody has a DVT, it may even break off the clot and cause a PE. The clinical triad of pain, edema, blanch appearance is termed phlegmasia alba dolens, painful white inflammation. And this is a more serious presentation of someone with a DVT. And the other one is the phlegmasia cerebellar dolens. It is a precursor to frank venous gangrene. Patient has severe swelling and the whole leg is cyanotic. So this is a phlegmasia cerebellar dolens. You can see the whole leg is very swollen and it's blue in color. And the other one is the phlegmasia alba dolens. You can see the whole leg is very swollen, but it's white. It's because the DVT is so severe that it causes the affects the arterial blood supply to the leg. So both of these conditions need to be addressed very urgently because patients can lose the leg or can even die from these two conditions. What are the differential diagnoses? Commonly it will be cellulitis, superficial thrombophlebitis, but there are also a list of conditions that can be a differential diagnosis for DVT. So, as you can see, tendinitis, arthritis, muscle tear, hematoma, soft tissue injury, fracture, swelling in a paralyzed limb, which is could be just a dependent edema, arterial insufficiency, peripheral arterial disease, renal failure, nephrotic syndrome, limb edema. So it is almost impossible to clinically diagnose or exclude DVT. However, the consequence of missing the diagnosis is serious. It must be excluded whenever it is feasible, when it is a feasible differential diagnosis. So the diagnosis depends on a high level of clinical suspicion and the presence of risk factors that prompt the diagnostic study. So you can appreciate that in the primary care, it's a very difficult scenario whereby to diagnose this condition. So there is this validated score called the WELL score, or the Dutch Primary Care Rule, in which there are certain signs and symptoms such as absence of leg trauma, active cancer in the previous 6 months, cuff swelling of 3 cm or more compared to the contralateral leg. When you actually measure it, 10 cm below the tibial tuberosity. Or is there any visible collateral dilatation of non-varicose superficial veins? Male sex? Is there any paralysis or recent immobilization of the lower extremities? Is there any pitting edema in the symptomatic leg? Is there any history of previous DVT? Is the patient recently bedridden for more than 3 days or had a major surgery requiring general or regional anesthesia within the previous 12 weeks? Is there the swelling of the entire leg? Is there tenderness localized to the distribution of the deep venous system? Does the patient take any oral contraceptives? D-dimer. Another diagnosis is as likely as or more likely than DVT. So here you get a score of -2. So once we have all these and then we score them according to the charts, so those patients with a score of 1 point or less on the WELL score or 3 points or less on the Dutch Primary Care Rule, they have low risk of DVT. All others are at increased risk of getting a DVT. So once we've done the scoring, according to the American Family Physician algorithm, if the scoring is low, then we perform a D-dimer assay. So if the D-dimer is negative, the DVT is excluded. If the D-dimer is positive or not available, proceed to request for an ultrasound venous Doppler. And once the ultrasound venous Doppler is negative, DVT is excluded, and if it's positive, the DVT is confirmed. If somebody has a score which is intermediate or high, we proceed straight to ultrasound. If the ultrasound is positive, the DVT is confirmed. If the ultrasound is negative, we perform a D-dimer, and if D-dimer is negative, DVT is excluded. If the D-dimer is positive, we repeat the ultrasound in 1 week. And again, if it's negative, DVT is excluded, and if it's positive, DVT is confirmed. So that is the guideline that has been suggested by the American Family of Physicians. So we may say that, to get a D-dimer assay may be a problem. It may not get it immediately in the primary care setting. So if that's the case, then go for ultrasound straight away. So this is the ultrasound venous Doppler. That's what it looks like. This is a longitudinal view of the femoral vein, and you can see that this here, the whitish image here, is the thrombus. And on the cross-sectional view, this is the femoral vein, this is the femoral artery, there's a saphenous vein here. You can see there's a thrombus here. Usually the veins are compressible, and if there is a blood clot inside, when you compress it with the ultrasound probe, it is not compressible on the image, on the ultrasound monitor. So that's how you diagnose DVT on the ultrasound venous Doppler. It's a very simple investigation to do. It's non-invasive, and it's very quick. Within a few minutes, you'll get the answer. So once the diagnosis is confirmed, we go for the treatment. Nowadays, the first-line therapy for non-high-risk VTE consists of direct oral anticoagulants. Now we have a lot of newer anticoagulants, such as these drugs, dabigatran, rivaroxaban, apixaban, edoxaban, all the bands over warfarin. So the advantage of these medications are that you don't need to monitor the INR, such as warfarin, and their levels, the dose are usually can be taken at the same dose all the time without any adjustments as compared to warfarin. For those with high-risk DVT or high-risk VTE, high risk for pulmonary embolism, then, as we know, there are parenteral treatments using heparin or low molecular weight heparins, such as clexane. And these are the treatments for during the inpatients. Now, barring any contraindications to aspirin therapy, aspirin is recommended to prevent recurrent VTE in patients with an unprovoked proximal DVT or PE following the anticoagulation cessation. So usually these patients are treated with anticoagulations for a certain period, and once it's finished, we can give them aspirin to reduce the risk of recurrence. And for the first episode of DVT, patients should be treated for 3 to 6 months on oral anticoagulation or oral anticoagulants. And indefinite therapy is recommended for patients with recurrent episodes of VTE, regardless of the cause. Consultations with the following specialists are indicated: hematologists, because they are experts in anticoagulation or coagulation, a vascular surgeon, a radiologist, or interventional radiologist. So the importance of this vascular surgeon or interventional radiologist is that they can actually treat the DVT aggressively, and it can actually remove the blood clots. This is a complication of DVT, post-thrombotic syndrome, PTS, which is what the patient had, the first patient that we discussed about in the beginning of the talk. You can see that the leg is swollen and it's really pigmented, and they always have ulcers which are recurrent, and it's very difficult to treat. So it affects their quality of life and it affects their livelihood. So how does it develop? So in a normal vein, we have valves that we know which prevent the reflux of the blood. So in DVT, there's this blood clot that is in the vein and around the valves. It causes inflammation, and therefore it damages the valves. And the valve becomes leaky, and there is a backflow of blood causing a stasis and venous hypertension, and which leads to the pain, the swelling, and the redness in the leg. And the difficulty about the deep veins is that once that happens, there's almost no surgery that can cure this. There hasn't been shown to be any valve replacement or any surgery that can effectively treat this condition. So patient is condemned for life. So PTS is a chronic complication of DVT, and that manifests months to years after the initial events. It affects approximately 50% of patients with DVT after 2 years. The symptoms can range from mild erythema, localized induration, to massive swelling that we saw on the picture and ulceration. And usually it is made worse by standing and relieved by elevation, as in any venous problems. It significantly reduces the quality of life. Regular use of graduated elastic compression stockings reduce the incidence of PTS by 50%. Now, I must comment that this use of graduated elastic compression stockings is what I find lacking in most of the treatments. The newer treatment methods. By treating the patients with anticoagulations, it's to reduce and prevent the blood clot from propagating and make it become worse. However, it doesn't remove the thrombus. So nowadays we have many new devices which can remove the thrombus effectively by percutaneously without any incisions or surgery. And stents, there have been a lot of new stents that's been developed, especially more important in treating the problems, congenital venous anomalies such as the May-Turner syndrome. Now, what we need to keep in mind is that these treatments are effective within the 2 weeks of patient's diagnosis or the initial presentation, because this will be considered an acute phase whereby the thrombus is still fresh and therefore it can easily be aspirated or sucked out or removed. After the 2 weeks, the thrombus becomes more organized, and therefore, if it's left for months and years, it's almost impossible to remove it. Now, by treating this aggressively, this will reduce the severity of PTS. So the idea is to help patients not develop PTS in the future. I'm just going to share with you one of the treatment methods in order to remove the blood clots. This is a short video. Now, this patient is positioned prone, and we put in the sheath and the wire through in the vein. So this is the device called the Aspirex, whereby it goes through the wire, and here you can see that mechanism that's spinning, and that creates a vacuum or vortex and sucks out the blood clots into this catheter here. So it's moved along the vein, and while it's going along, it aggressively sucks out all this thrombus, as you can see. So this is done under image guidance, which means under X-ray. And so the idea of removing the blood clot is that it doesn't remain in the veins for long, which then leads to the damage of the valves. And so there you go, all these blood clots are removed, the valves remain open. So this is the next video is looking at the anatomy and the use of the stent. So May-Turner syndrome, this is the iliac vein, usually it's the left iliac vein that's compressed, and see the blood clot that is here. So we put a wire through the blood clot and then put in the stent in, and then we pushes and the stent will push the blockage open. The principle is the same as we do for coronary angioplasty, only that this is done in the vein. And the narrowing, once it's open up, then the blood can flow freely, and that will then relieve the blood of stasis. And nowadays the stents are very flexible and it can move with the movement of the patients, because otherwise there would be a risk of a stent fracture. Okay, so this is one of the patients. You can see that before the procedure, this is the groin here, and as you can see the contrast going up in the vein, and here it's completely occluded and you can't see any more contrast going up in the inferior vena cava. So this patient was then treated with a thrombectomy, which means that all these blood clots up here are removed, and after the removal of blood clot, the stent was positioned in to keep the vein open. And this is the picture showing that after the treatment procedure, the blood is able to flow freely. And you can see this is the vein and the contralateral vein. There's no more blockage. So in conclusion, the diagnosis of DVT depends on a high level of clinical suspicions and the presence of risk factors that prompt the diagnostic study. Referral to the appropriate specialist is important. Early recognition and treatment reduces the severity of post-thrombotic syndrome. Treatment consists of anticoagulation, elastic compression stockings, and removal of thrombus or stenting of the vein, not just anticoagulation. And with that, thank you very much for your attention. We go for the Q&A sessions. So the first question comes from Dr. Nagaratnam. Can aspirin and anticoagulants be given at the same time? The answer is yes, it can be given at the same time, but in order to do that, the patient's risk factors and the risk for bleeding should be considered compared to the benefits of these dual treatments. But having said that, usually in terms of DVT, only anticoagulants is enough, majority of the time. Question number two is again from Dr. Nagaratnam. Can stents prevent backflow? The answer is no. The stents function is not to prevent backflow. Usually the stents is used to treat wherever there is areas of stenosis. And for example, there are areas of stenosis whereby the vein is being pressed upon by the artery and therefore narrowing the lumen of the vein. So the stent is put in to keep the lumen of the vein open. Question number three, Dr. Bernardine Malini Martin. How long do the stents last? The stents are meant to last permanently. However, there are always, as with any stents, there's a risk of stents getting occlusion, getting a blockage, or sometimes the stents may migrate or may move, but these are not common if the correct size of stent is put in and the correct stent is put in.
Thank you, Dr. Ho. So are there any more questions from the audience? If you have any more questions, you can type into the comment box right now. Okay, I see there's one question.
Okay, question from Dr. Chui Weng Huang. Elastic compression is difficult to use in our climate. Please elaborate how patients may be motivated. Yes, I agree. Even for varicose veins, patients don't like to wear the compression stockings. They will complain it's very hot, sweaty, it gets itchy. And furthermore, it's very difficult to put on because it's very tight. So how do we motivate the patients to wear the stockings? I don't know, it's very difficult, but if the patients are explained and be informed about post-thrombotic syndrome, and if they see the pictures of PTS, I hope that would be enough to motivate them. Dr. Sunita, what's the duration of anticoagulation? So for the first episode of DVT, usually the duration is between 3 to 6 months. Of course, during this time, the patients will need to be re-evaluated with an ultrasound scan. And if they have recurrent DVTs regarding of any cause, then it will be an indefinite anticoagulation. So, Dr. Bhupinder Kaur, what about patients in remote areas? What best can be done for them? Well, I think in remote areas, as a GP, you may have difficulty to access the treatment modalities and investigations. I think if there is any suspicions of DVT and the patient has very low risk of bleeding, it may be wise to start treatment first and then get investigations done later. Dr. Gerard Nunes, what is the role of IVC filters to prevent pulmonary thromboembolism? The role of IVC filters, they are actually looks like an umbrella, inverted. It is made of metal with a lot of bars, and that is to be put in the IVC to prevent the blood clots from traveling up above it. And usually it's certain physicians or certain doctors, they will put in these filters if they see that there is a patient with proximal DVT, which means that there is a DVT in the iliac vein and the femoral vein. In addition, those patients who have got these proximal DVTs and they are contraindicated to have anticoagulation, it is also another indication of putting in an IVC filter. Next question is Dr. Muhammad Osman. How long should patient take NOAC after stenting? So usually the treatment course of the DVT is 3 to 6 months, irrespective of input stent or not. So after that duration, this is debatable in terms of what we should treat the patient with, whether we should give them antiplatelets or some low-dose NOAC. There isn't any consensus with regards to that at the moment. Next question is by Dr. Sri. In cases of recurrent DVT, how long can you continue treatment? In cases of recurrent DVT, most of the times it is recommended that to continue treatment indefinitely with anticoagulation. Okay, I think that may be the end of the session. Thank you.